Good afternoon. Whilst we wait for people to come in, we thought we'd just, in the interest of time, just to get started. My name is Iskandar Azwa. I'm an infectious disease physician in University Malaya, and I'm also president of the Malaysian AIDS Council. Currently, this is a satellite symposium. It's entitled Overcoming Barriers to PrEP Innovations, to PrEP and Innovations in HIV Services in Malaysia. And we want to tell you our story. We have 4 exciting presentations from a combination of Ministry of Health, pharmacy-led PrEP services, from corporate sector, and myself, and how we've overcome certain challenges which are specific to the country, including the context of challenges around sexual orientation, as well as funding, along with differentiated service delivery models. My colleague and my mentor, Prof. Adiba Kamarul-Zaman, was meant to chair this session. As you can see, she's already online, so I welcome her to the stage to give her opening remarks. Thank you, Adiba. So you're muted, Adiba. You're muted. Yep, sorry, we still can't hear you. Okay. Could it be our side that's a mistake? We're looking into it? Okay, sorry, we're just looking at it at the moment, and it's probably an operational point on our side. You can hear her? Okay, can you try and turn up your volume, because...
It's as high as
okay.
it could be.
There you go.
You can hear me now?
We can hear you crystal clear now, thanks.
Excellent, excellent. So a good, very late evening from Kuala Lumpur, Malaysia, everyone. My name is Adiba Kamarul-Zaman. I'm the chair of the Malaysian AIDS Foundation and the immediate past president of the International AIDS Society. It's really unfortunate that I can't be with all of you to this satellite symposium, and indeed to the entire AIDS 2024 conference due to unfortunate work commitments that I have in my new role here at Monash University. I am very pleased to, despite our distance, very pleased to share the stage with my esteemed colleagues Iskandar, Dr. Anita, Dr. Mazliza, from Ministry of Health, and Yaniv, who's going to share her PhD work on PrEP delivery amongst pharmacy, and of course, Nick Tasha from the Sunway Group, who has been instrumental in many ways as a corporate partner to the Malaysian AIDS Foundation. As Iskandar alluded to, it's not, well, PrEP has been around for many, many years now globally, but it's not been an easy path in Malaysia for many reasons. Malaysia is a very conservative society, and it took some time for the community to embrace PrEP, but we now have it. Certainly, Ministry of Health is doing everything it can, despite opposition sometimes, to roll it out. So it gives us great pleasure to share with you, or for my colleagues to share with you, the journey to implement and expand PrEP to scale in Malaysia, and of course the importance of corporate partnerships and well, the whole corporate, academia, community, Ministry of Health partnership, as we all, I know that you have all heard in the last few days how important that is, particularly in this funding climate. So hopefully there will be some lessons learned from the journey that we've had in Malaysia. And I wish you all the remainder of the conference a very, very good time at AIDS 2024 and in Munich. Over to you, Iskandar.
Thanks very much, Adiba, for those opening remarks. I understand that you're probably going to stay online, but if you have to go, we also understand that. It's quite late there, so we'll leave it in your hands. But thank you very much for those opening remarks. So first up, we have Dr. Anita Sulaiman. Dr. Anita Sulaiman has been leading, is a leading public health physician with more than 27 years of experience in controlling communicable diseases. She's very well known for her innovative work in HIV prevention, including developing key strategies and policies that have impacted and left a mark in the HIV efforts in Malaysia. Her efforts in particular have led to the elimination of mother-to-child transmission of HIV and syphilis and influenced Malaysia's goal to end AIDS by 2030. Dr. Sulaiman has also played a critical role in managing pandemic outbreaks such as the H1N1 and was recently, until very recently, the Director of Disease Control at the Ministry of Health in Malaysia. She will be speaking about harmonizing health and belief, PrEP journey in Malaysia, and really touching on navigating HIV prevention policies in a predominantly Muslim country. Thank you, Dr. Anita.
Thank you, Prof. Iskandar, for your kind introduction. Good evening, everyone. Thank you for joining us today. I'm here to present a very significant and timely topic about PrEP, harmonizing health and belief on the PrEP journey in Malaysia. We will explore how Malaysia integrating PrEP into our primary care service in Malaysia within its, especially knowing Malaysia a Muslim majority country. Let's dive into the topic that we're going to talk today. Okay, but this one. Forward. Okay, now it's moving. Okay, all right. Thank you. So these are the outlines of my topic today. The objective is to understand why we need PrEP as part of our HIV prevention package and how it fits in the context of Muslim majority country like Malaysia. We will look also at the challenges and strategies employed to harmonize health and belief in Malaysia. It's a bit slow. Okay, all right. It's a bit slow. All right. Now, to start our discussion, I would like to share with you about the HIV landscape in this country, in Malaysia. We have seen a significant shapes of HIV epidemic over the last decade. The HIV in Malaysia has always been with the males, all right? But the proportion of females infected with HIV has risen from 1% to 11% over the past 3 decades. The epidemic is still concentrated among key populations that include men who have sex with men, people who inject drugs, transgender population, and female sex workers, with prevalence of HIV above 5%. The recent data shows that HIV primarily affects younger individuals aged 20 to 39 years old. It is important to note that HIV does not know boundaries. Muslims are not spared. Thus, it is paramount that effective prevention strategies, including pre-exposure prophylaxis or PrEP, must be employed without prejudice. Okay, next one. Now, this chart clearly shows the shift of HIV transmission mode in Malaysia. Initially driven by people who inject drugs, the epidemic has shifted to predominantly sexual transmission since 2010. Today, 60% of new cases are among homosexuals, 36% among heterosexuals, and only 2% among people who inject drugs. It was once upon a time, people who inject drugs was the key population that has driven the HIV epidemic in this country. This transition calls for a robust and adaptive response to this dynamic change. Okay, now this graph is showing the trends of HIV prevalence among four main key populations in Malaysia between 2012 to 2022. Now, the prevalence of female sex workers and people who inject drugs has decreased by more than half between this period 2012 to 2022, and this is being attributed to the implementation of harm reduction program that was initiated in 2005, 2006, that entails needle exchange program and methadone replacement therapy. Conversely, we can see the other two key populations, namely the MSM and transgender population. You know, especially the MSM population, there was a notable rise. Okay, that we saw between 2012 to 2022 from 7.1% jumping to 12.9%, and this persistent upward trend highlights the urgent necessity for the targeted interventions, including PrEP. Okay, now this is important graph that is showing effectiveness of PrEP program in ending AIDS in Malaysia. Now, if you see the blue line, it represents the estimated HIV infections under the current spending without any changing to PrEP allocation. And the red, the green, and the purple lines representing the estimated new cases with different funding models on PrEP. The introduction of PrEP in a co-payment model, indicated by the green line, and fully funded by the government, shown by the purple line, both result in a decrease in new infections. And this model explains the importance of government support, whether it is in a co-payment model or is it fully funded by the government. And this could lead to a substantial reduction of new HIV infections, moving us closer to the goal of ending AIDS in 2030. All right, now let's delve into the Islamic ethical considerations surrounding PrEP use in Malaysia, which has been pivotal in its implementation in our country, being a Muslim majority country. One of the primary objectives of Islamic law, or Maqasid Sharia, is preservation of life. Okay? PrEP, which effectively prevents HIV infection, aligns with this objective by protecting individuals from a life-threatening disease. Second, Islam places great emphasis on prevention of harm or darar. The Prophet Muhammad, peace be upon him, said there should be neither harming nor reciprocating harm. PrEP can be seen as a tool to prevent significant harm caused by HIV, thereby aligning with this principle. Third, seeking medical treatment or tadawi is encouraged in Islam. The Prophet Muhammad, peace be upon him, said, "Seek treatment, O servants of Allah, for Allah has not made a disease without appointing a remedy for it." Now, if you look at this, PrEP, as a pharmacological preventive measure, falls within the scope of seeking treatment to prevent future illness. Fourth is ethical use of resources. Okay, ethical use of resources is crucial in Islamic ethics, ensuring that PrEP is accessible to those at high risk of HIV infection can be seen as just allocation of medical resources, promoting overall public health. Now, this is the roadmap, a PrEP roadmap in Malaysia. The PrEP's milestone in Malaysia traces a path of proactive measures and strategic implementation. We have made significant strides from our inclusion in our National Strategic Plan on Ending AIDS to the launch of fully funded PrEP government project in 2023. Between 2016 and 2018, here, efforts to understand public willingness and train healthcare providers on PrEP begin, alongside making PrEP more visible and well understood by the community. In 2020, PrEP delivery was initiated, but at limited sites. This limits the coverage of PrEP to only those who could afford it. Okay. The effort to scale up PrEP implementation began in earnest in 2022. And this journey commenced with a series of formal and informal discussions with Muslim religious groups and Muslim scholars, alongside the challenges of obtaining pharmaceutical registration for antiretroviral as prophylactic indications, testing our resilience. Although there is no fatwa as yet, in November 2023, Perlis, which is the northern part or northern state of Peninsular Malaysia, issued a state fatwa stating that it is permissible for doctors to prescribe PrEP. And this has marked a significant milestone in aligning health initiatives with cultural and religious consideration. The PrEP government project finally launched in January 2023 as a pilot study, mainly to assess the acceptance of the community to come to the government setup to take PrEP first. The second is to also assess the acceptance of our healthcare provider to provide PrEP, okay, if PrEP is made a policy in Malaysia. Okay, as widely understood, PrEP is recommended for individuals who engage with high-risk behaviors, such as those with HIV-positive partners, those with multiple sexual partners, or individuals who inject drugs. When taken consistently, it can reduce risk transmission by 99% through sexual contact and 74% through shared needle. Many countries worldwide, such as Australia, Brazil, and so on, have already shown a positive impact on PrEP program in their country by reducing HIV cases constantly. And those countries employed proven successful strategies outlined here and that we all could learn from. First is early adoption. Australia was among the first countries to implement PrEP and successfully reduce their numbers and keep them on track for ending AIDS. And they are on track to reach 2030 ending AIDS goal. Government support is important to ensure affordable and accessible PrEP for all, regardless of their social status. Collaboration with local community organizations and peer organizations helps to promote PrEP awareness and education and sustainability, right? PrEP should focus on key populations, including men who have sex with men, transgender populations, people who inject drugs, and also sex workers. Ongoing research and monitoring is important to track PrEP uptake and adherence and its impact on HIV incidence. To date, there has been no report on Islamic majority countries other than Malaysia and Indonesia that have implemented PrEP as part of HIV prevention package. Malaysia's PrEP model was started in 2020 as a pilot intervention, which at government health clinics. I repeat again, at government health clinics, co-funded by Global Fund. There is no unified fatwa as yet, as I mentioned just now, but I think having one state issuing a positive fatwa that's supporting PrEP, I think is already something very positive to start with. The Malaysian model emphasizes behavior change, communication through the ABCD approach. I think some of you might recall back during the earlier pandemic of HIV, that how we teach people about ABCD. Now, about ABCD will be explained further by our second speaker. Right? It's A, abstinent, B, faithful, condom use, and don't do drugs, and last, PrEP is last resort. And this is important because this aligns with Islamic values and promotes responsible behavior. Community-led PrEP navigators placed in government clinics that run PrEP program is very crucial because they assist in the recruitment of the community or key population, help them to adhere with PrEP, and also at the same time help to eliminate stigma and discrimination among healthcare providers. PrEP awareness in Malaysia is conducted discreetly within key population network to avoid public backlash. We don't go all out, in public, in general public, saying that we must go for PrEP and things like that, because we understand the sensitivity of this issue, especially in Muslim majority country like Malaysia. So we chose to have it discreetly, as in focusing on selected or among the key population networks. Okay, now introducing PrEP in Muslim majority communities is not easy, right? It comes with challenges. One potential concern is that PrEP might be perceived as encouraging premarital and extramarital sexual activity, which we all know prohibited in Islam. However, it is crucial to recognize that PrEP is a medical intervention aimed at preventing disease, not endorsing specific behaviors. The ethical focus should be protecting individuals from harm regardless of the circumstances. There may be stigma associated with HIV and its prevention within some Muslim communities. Addressing stigma through education and awareness is essential, emphasizing that preventing disease is a shared responsibility and also a compassionate act. Islam values informed consent and autonomy of individuals to make informed decisions about their health. Healthcare providers should ensure that individuals are fully informed about PrEP, the benefit, the risk, the side effect, all right, and the future and planning their PrEP plan for their future, and allowing those people or the communities to make informed decisions. Using PrEP as part of a broader public health strategy to reduce HIV transmission aligns with a collective responsibility to protect and promote health within the community. To improve PrEP uptake and effectiveness, we would like to share with you some recommendations, right, how to integrate PrEP into national HIV strategies. This involves creating clear guidelines and protocols for religious and cultural sensitive PrEP users, establishing a supportive legal framework will protect the rights of individuals using PrEP, reduce discrimination, and ensure confidentiality. Increasing funding through government or maybe international partnership is paramount to ensure affordability and accessibility of PrEP to everybody, those who need. Strengthening healthcare system is also essential. Having mobile and community-based services like screening can enhance access, especially to underserved population or the key population. Working closely with religious groups and community leaders will facilitate PrEP through endorsement and promote the benefit of PrEP among Muslim community. Their support can help mitigate resistance and encourage community acceptance. Robust monitoring and evaluation also will ensure continuous improvement. Here are some practical insights to consider, especially for Islamic countries. Healthcare providers should communicate with cultural sensitivity and involve family and community leaders in educational sessions. Confidential and discreet service delivery is crucial to protect patients' privacy in order to avoid stigma. Education approaches should frame PrEP within Islamic teachings that emphasize preservation of life. Community-based interventions such as peer education and community outreach worker can improve adherence and support, and subsequently getting the buy-in from community to come forward to take PrEP. Integrating PrEP with sexual health services and leveraging technology for information and support can enhance overall effectiveness. In conclusion, implementing this policy recommendation and practical insights can significantly improve the uptake and effectiveness of PrEP programs in Islamic countries by reducing cultural and religious norms, by respecting cultural and religious norms, ensuring confidentiality and providing comprehensive support. Healthcare providers can effectively promote PrEP as a vital tool in the fight against HIV. Through collaborative efforts and sustained commitment, these strategies can help protect the vulnerable populations and enhance public health outcomes. With that, thank you very much.
Thank you very much, Dr. Anita, for that, really highlighting the challenges that, what a majority Muslim country can go through, which other countries may not necessarily have to really think about, really in terms of respecting cultural and religious norms. What I think Dr. Anita also underplayed was, her humility and leadership around a lot of the backlash that happened. And without that leadership, we may have told a completely different story. I'd like to invite Dr. Masliza up next to the podium. Dr. Masliza is also a public health physician and currently focusing on HIV, STIs, and hepatitis C at the Ministry of Health. She manages key projects like the Integrated Biobehavioral Survey and on national HIV estimates. She's also worked tirelessly on scaling up PrEP within the government sector and has been also leading the clinical efforts around that, including research and policy changes which have significantly changed public health in Malaysia. The title of her talk is, she'll be talking about the PrEP government-led PrEP services and community engagement and the lessons learned from implementation. Thank you.
Thank you, Prof. Iskandar, for the kind introduction. Assalamualaikum and a very good evening to everyone. I will continue our symposium today by presenting on the government-led PrEP services in Malaysia, commonly known as the PrEP-Gov program, and the significant role of community engagement in the program. As mentioned by Dr. Anita in her slides just now, the epidemic in Malaysia is now predominantly driven by sexual transmission and increasingly affects the younger individuals. To address these shifting dynamics, it is crucial to implement a new and effective strategies to combat the spread of HIV and to protect those most at risk. One scientifically proven intervention for HIV prevention is PrEP. But why should we incorporate this program into our existing initiative? First, it has proven as an effective HIV prevention tools for key population in which PrEP provides a critical, protective measures for those who are at most and vulnerable to HIV. And secondly, PrEP complements the existing prevention methods, creating a robust and comprehensive HIV prevention strategy that addresses multiple transmission routes. And thirdly, behavior change supports in which the integrating PrEP into prevention programs encourages individuals to adopt a safer sexual practices and to seek regular health checkup, fostering a culture of proactive health management. And next, addressing structural factors in which PrEP will help to mitigate structural barriers that increase HIV risk, such as stigma and lack of access to the healthcare facilities, and ensuring a broader reach and impact. And lastly, health equity and human rights. By making PrEP accessible, we uphold the principles of health equity and human rights, ensuring that all individuals, regardless of their background, have the means to protect themselves from HIV. Okay, next, let's see the implementation of the HIV program in Malaysia, where the services is available, what delivery model do we use to its rollout in the government health clinics. These are the sites where the government health clinic have provided the PrEP program. Starting with 18 clinics last year in 2023, the program has now expanded to a total of 31 clinics this year, making it available in all 14 states in Malaysia. And this is the HIV PrEP care concept that we implement in Malaysia, which integrates community and health clinic efforts to ensure an effective prevention and is employ a multi-tiered approach. Our model integrates PrEP services into primary health care, ensuring a seamless support from the community to the clinical assessment to regular follow-ups. And risk reduction counseling is the key component in our model, in which throughout the process, risk reduction counseling is provided to support individuals in making informed decisions and maintaining their health. And the model starts from the community, where they themselves, the community, play an important role in our PrEP program. Their role is to ensure a seamless and continuous support from the communities outside the clinic settings for our PrEP program. Firstly, in service linkage, our goals is to increase the PrEP uptake by leveraging existing services such as outreach program for key population, community-based testing, and also the HIV self-testing. This initiative is spearheaded by the community-based organization across states, ensuring an extensive reach and localized support. And secondly, the crucial role of communities in creating demand generation. The communities will generate demand for PrEP through normalization, peer motivation, online promotion, and a continuous campaigns, which ensuring a better health-seeking behaviors among the key population. And next is the role of communities in PrEP advocacy, in which the community work to debunk myths about PrEP and reduce shaming and stigma related to PrEP usage. And lastly, we also emphasize the role of communities in improving PrEP adherence, and in one of the key strategies in this improving PrEP adherence is the formation of a PrEP navigator. And who are the PrEP navigators? They are the community health workers who are based in PrEP clinics, act as guides and educators to the community. Their primary objective is to facilitate access to PrEP services and to ensure clients adhere to their medication and appointments by supporting clients throughout their PrEP journey. And next, we explore the Malaysia PrEP care model implemented in our health clinics. While the community involvement play a crucial role outside the clinic setting, within the clinic itself, the PrEP care model underscores the central role of the healthcare providers in supporting PrEP users. In this model, guides the individual from initial eligibility assessment and baseline counseling through to a regular 6-month follow-ups, with a strong emphasis on risk reduction counseling and seamless integration of the PrEP services into our primary healthcare setting. And one of the critical components of our model is the risk reduction counseling, in which in this risk counseling, it is implemented across various levels of the models. The community health workers conduct it at the community level, while the healthcare providers or the PrEP navigators conduct the counseling within the health clinic setting. It is a comprehensive framework designed to reduce the risk of HIV effectively. First component is the awareness and assessment, in which these steps involve educating individuals about the various risk factors associated with HIV and the benefit of PrEP. Alongside education, we also conduct initial and ongoing risk assessment, and it also helps to identify individuals' risk level and also to tailor the counseling process to address specific needs and behavior, making the interventions more effective. As for the B component, or is the behavior intervention, in which we focus on encouraging safe sex practices such as consistent condom use and regular HIV testing. Additionally, we also include strategies for reducing substance abuse, which can increase risky behaviors and also the risk of HIV transmission. We apply the ABCD of HIV prevention strategy during counseling, in which it provides a reliable framework for behavior change. During counseling, we also emphasize on adherence to PrEP, and it is also important to remind our client during the counseling that PrEP is not necessarily a lifelong commitment, and they can opt for other prevention strategies. And next is the counseling support, in which we also train our community workers and also our healthcare workers to provide both psychosocial and psychospiritual counseling. The psychosocial counseling addresses the mental health issues, helping the individual to cope with the emotional and psychological impact of being people at risk for HIV. While the psychospiritual counseling, on the other hand, we focuses on spiritual concerns and stigma, and which can be significant barriers to effective risk reduction. By addressing these areas, we try to provide a holistic support system that empowers individuals to manage their health and well-being more effectively, to ensure adherence and to address mental health challenges. And lastly is the documentation and follow-up, in which maintaining detailed records of each counseling session is vital for tracking progress and outcomes, and these records will allow the counselors to monitor changes in the behavior, adherence to PrEP, and other key indicators of risk reduction. And regular follow-ups ensure ongoing support and necessary adjustment, maintaining intervention effectiveness and providing individuals with continuous support. Next, I will present our PrEP-Gov project preliminary results from January to December 2023 cohort. We initially pre-screened about 3,500 participants. After all the exclusion, there were about 3,451 people who started PrEP at baseline. And during the screening process, or the first month of PrEP, our program have detected about 76% of HIV reactive. This constitutes about 2.2% of the screened population. Of those who began PrEP, about 700 individuals discontinued the program for various reasons. And as of 1st of April this year, about 2,676 individuals from this cohort remain actively enrolled in the program. Enrollment number consistently range between 200 to 300 each month, except in December when it dropped drastically to about 100 clients for that month. However, this drop followed a PrEP stockout in November that we have, which significantly hindered our ability to enroll new participants. Fortunately, this issue did not affect our existing clients, who continued to receive their medication supply without interruption. And this slide highlights the HIV risk factors reported by participants prior to enrollment to our PrEP program, and the majority had a history of STI, followed by those who had unprotected sex, felt at risk, and engaged in camp-fun activities. These factors underscore the need for targeted PrEP intervention. And as for the demographic of PrEP users in our program, The majority are single men, aged 25 to 49, predominantly employed, with about 87% of them being MSM. And most have accessed PrEP through NGOs and prefer a daily dosing regime. It is interesting to see that the program attracts a significant number of young individuals from key population. And besides that, there is about 23% are walk-in clients who had not previously been approached by the community health workers from NGOs and had never been screened for HIV or STIs. And these individuals represent a high-risk population, and without the program, the PrEP program, we might not have been able to reach them until they were already infected with HIV or STIs. And this is the PrEP retention rates as of 1st of April this year. The retention of month 1 or M1 is about 91%, at month 6 about 87%, and at month 12 about 87.5%, which indicating a strong adherence over time among our clients. Next is the outcome of the PrEP program. The HIV seroconversion rate among PrEP users is about 0.2 per 100 years, with 6 cases reported, and these cases were associated with suboptimal adherence. Comparatively, this rate is significantly lower than those reported in other regions, such as the Philippines and Thailand, and highlighting the effectiveness of the program in Malaysia. And besides HIV seroconversion rate, we also monitor the behavioral change among PrEP users. And condom use is increased from 29% at baseline to 40% at month 6 and slightly decreased to 32.6% at month 12. And the client with monogamous partners rose from 7.2% at baseline to 31.5% at month 6 and month 12. And the prevalence of syphilis significantly dropped from 11% at baseline to 5.9% at month 6 and month 12, indicating a positive outcome in risk reduction and sexual health behaviors. In conclusion, the program demonstrates a low HIV seroconversion rate, indicating its effectiveness. It fosters positive behavior change and showcases high retention rates, reflecting strong adherence with the help of a community through the PrEP navigator stationed at the health clinics. And the program increases HIV screening among the key population and emphasizes strong community collaboration, which is essential for sustained health outcomes. And the risk reduction counseling is crucial for long-term behavioral change, as this program is not only about the pills, but combining all HIV prevention. And the program is cost-effective, reducing the healthcare system financial burden by preventing new infection, and additionally, it empowers individuals through education and improve the overall quality of life for those who are at risk. As a take-home message, the results of the HIV PrEP program in Malaysia underline the critical role of the program in prevention. PrEP have been indispensable for filling the gaps left by other prevention or intervention, and any reason to exclude PrEP would risk impeding Malaysia's progress to end AIDS by 2030 and even perpetuates the epidemic of HIV. The PrEP program is not only about prescribing a pill, but it can serve as a platform to engage with the key population and fostering a culture of proactive health management. Our model emphasizes on risk reduction counseling, and this flexible approach ensures that everyone can find prevention method that works best for them, for their situation, rather than relying solely on PrEP for HIV prevention. In conclusion, PrEP holds immense promise in our battle against AIDS. By embracing evidence-based strategies, integrating PrEP, and fostering community engagement, we can move closer to our goal of ending AIDS by 2030 without leaving anyone behind. With that, I end my presentation. Thank you.
Thank you very much, Dr. Masliza, for outlining what's been happening, certainly from the public health sector, and some of the lessons learned, and how we can potentially scale up even further. Right, so I'm going to be talking up next as part of a duo act with my colleague and one of my favorite PhD students, Yanni. I will go first. So I'll be talking about, of course, in situations where stigmatized settings, you'd want to make PrEP more accessible settings also beyond traditional clinical settings as part of a differentiated service delivery model. And I'll be talking about some very, very early findings of our JOM PrEP, mobile health differentiated service delivery. So what is mobile health? Mobile health is the use of mobile and wireless technologies to achieve improved health goals. It's a subset of e-health, which essentially refers to the use of information communication technologies in support of health and health-related fields. We know that digital technologies are becoming an important resource for delivery of public health services. Mobile health in particular is particularly attractive due to ease of use, wide acceptance, and broad reach. This is the integrated biobehavioral surveillance reporting on HIV prevalence of key populations in Malaysia. This has been shown, essentially showing that the predominant population being affected by HIV in Malaysia has been MSM. This sort of peaked at about 21.6% and in 2022 reported 12.9%. And once again, some data from the Integrated Biobehavioral Survey in 2022, looking specifically at PrEP uptake. This was before the public health sector scale-up, reporting very low rates of PrEP uptake in the past 12 months of 11.8. So this is end of 2022. And really a potential for other areas, including pharmacy-led PrEP and an online service form of PrEP delivery to be considered. And this is part of these are repeated themes within this conference. As part of a differentiated service delivery, we need to bring PrEP also to where the patients are. And the reality of the situation when PrEP was being introduced, essentially in the public health sector, it received a lot of backlash and actually probably not too unsurprising. But it did receive quite a bit of backlash from religious academics, religious leaders, religious doctors. And it was a very trying time for a lot of us who work in HIV prevention, having to defend the public health initiative for HIV prevention. This, of course, was not new. I mean, we've been here before with harm reduction in the form of opioid substitution therapy, and some of the lessons from there could have been applied to the backlash that happened subsequently. And therefore, navigating HIV prevention policies and Islam in Malaysia can be very, very difficult because you always need to put, understandably, respectful religious conversations into that conversation. Looking at barriers and facilitators, this is within focus group discussions amongst both MSM and community stakeholders. Some of the barriers to PrEP use identified then was high costs associated with private sector PrEP servicing and limited knowledge at the time of PrEP. And some facilitators was use of government subsidy to reduce costs, simplification of service delivery, and the need and increase the number of service delivery models, be it telehealth, pharmacy-led, or key population-led services. We know that the use of smartphone in Malaysia, but also across the region, has significantly increased over the past 10 years. This is amongst a cross-sectional survey of 376 MSM between July 2018 and March 2020. 97.9 accessed or had a mobile phone with internet access, of which 99% accessed the internet daily, mainly through a smartphone. There was high acceptance of the use of mHealth and HIV prevention within this group, and there was a preference for using a smartphone app over other modalities. But there are gaps in mHealth research in Malaysia, particularly as a lot of this applies to high-income countries. There's a lack of focus on comprehensive HIV prevention strategies. They tend to act in silos. And a lot of the existing mHealth apps that are being studied are currently being studied in silos and are not being integrated into clinical platforms. So Jom Prep is an existing mHealth app. It was adapted from a pre-existing app called the HealthMinder app, adapted to the Malaysian context to create a new clinic integrated app to deliver holistic HIV prevention services, which encompass HIV testing, PrEP, support services for mental health and substance use, which is a key element of the app amongst MSM in Malaysia. It retained the core features of the original app, which were essentially HIV risk assessment, HIV testing plan, reminders, and ordering of test kits. What additional features were added were essentially the virtual access for HIV prevention services called PrEP Express, such as appointment booking for HIV testing and PrEP services, a chat function to communicate with staff, and a test result feature that enabled participants to access their laboratory results. Other features included include e-consults, discrete door-to-door service delivery, and notifications. And this is essentially what it looks like. That's the front end. You have a health tracker where they can track their medications as well as their mental health. You can order a HIV self-test through the app. You can track your appointments, and you can track your whole PrEP order through the app. Once again, as mentioned, there was an emphasis on mental health screening with online assessment tool with PHQ-9. And if they scored above a certain amount, and if they were categorized as moderate to severe depression, they were then subsequently provided with a directory of service providers and an email with a referral letter. And this is the office dashboard, which research staff had access to a various number of activities, as you can see on there, as well as a clinic dashboard, which essentially clinical staff from affiliated clinics could facilitate patient care. And in the absence of an electronic health record, this sort of functioned as close as possible to an electronic health record system. So in terms of timelines, and in the interest of time, I'll just rush through this. Following conceptualization, there was a period of theater testing to examine format, content, features, and feedback from participants. Then this was used to build a prototype whilst maintaining fidelity to the core elements. This was then subjected to alpha testing, essentially with mainly testing of the different elements on the app until it was refined to form the final beta version. Some initial results from this amongst 50 MSM using the app over 30 days essentially showed that the majority of the users were Android users. 2 outcomes were looked at: user engagement and app acceptability, one of them of which was participants' app use. There were 8 unique visits over 30 days, and the duration was about 28 minutes per session. The app acceptability score was 73.8 and well above the 50 threshold mark on the system usability scale. Beta testing, essentially over 30 days, showed that majority of participants could order a HIV self-test kit using the app, and about 92% of participants used the app to get on PrEP. Most participants chose same-day PrEP, and majority of them picked up their PrEP medication at the pharmacy. Interestingly, 88% of participants used the online assessment tool to screen for depression, and 89% of them met the criteria for moderate to severe depressive symptoms and were provided with a referral letter. There was high levels of satisfaction with the app. Currently, it's in a randomized controlled trial stage, looking in the form of a hybrid implementation effectiveness design, so looking both at efficacy but also implementation outcome. Very quickly, they randomized 1-to-1 either to the intervention group, where there was full access to app features, and a treatment as usual group, whereby they were provided a link to a resource page with educational materials around HIV testing and PrEP, and a referral letter to a local PrEP provider. Follow-up was over 9 months at 3, 6, and 9 months. The primary outcome is HIV testing uptake, PrEP uptake, and secondary outcomes were PrEP adherence and PrEP persistence. These were integrated with 8 private clinics across Malaysia, and implementation was more reflective of real-world scenarios. We also are planning to look at implementation outcomes using the Consolidated Framework for Implementation Research, and there were 11 constructs based on the relevancy to our study as listed there. Currently, we have screened 647 patients, and of which 304 were eligible and 198 completed baseline, of which half have been randomized to the intervention arm and another half to the control arm. Now, I have not, in the interest of time also, I won't go through the implementation through the outcomes of that, but we'll move in to some of the concerns we have generally with mHealth apps. There are huge ethical concerns generally in the use of smartphone apps for HIV prevention, and this was from qualitative data from 23 MSM from focus group discussions. The major concerns were unsurprisingly privacy and confidentiality themes, mainly in the form of uploading personal information, setting up account, concerns around the app visibility and how it can stigmatize them to sexuality, how they get the notifications, their photos and avatars. Data ownership was also a particular concern, particularly around government access to stored data and data management concerns, as well as data storage, in particular location of the server and reputable operator. There were concerns around equity, particularly with the MSM, and that some felt that MSM, the younger MSM may not be able to access PrEP through the app, and those with low income. Regulation, highly important. Questions were raised around who should endorse this, ministry versus the wider community. Quality control of medication was a repetitive theme brought up, as well as assurance of HIV test quality. So in conclusion, challenges to mHealth implementation and adoption, in addition to what was mentioned, include privacy and data security, platform compatibility with wireless networks, concerns around network access, particularly in rural areas, and of course, costs. And who reimburses at the end of the day is the question that everybody's going to ask. And when thinking about this, it's important to think about integration into existing electronic health records. Otherwise, this will not scale up. Digital literacy is of course important, especially with respect to the older population. This needs to be addressed. And when thinking about this, we need to think how different mobile apps come together rather than working in silos. And there are other projects that we're doing in different populations listed there. And with that, I'd like to acknowledge our collaborators from University of Connecticut and Yale. They're all listed there. And Kamal, who's present in the front seat from University of Connecticut, who also has led on a lot of the work that I've presented. Thank you very much. So next up is Yani, who's going to present on pharmacy-led PrEP. All I can say about her, she's a super duper PhD student, and that's all you have to know.
Good evening, everyone. It's certainly a very nice, heartwarming feeling to be introduced by a PhD supervisor in such a lovely way. My name is Yenny. I'm a pharmacist and a PhD student at the University of Malaya. I'm also working at the Ministry of Health, Malaysia, but I'm currently on study leave. Thank you to the organizers for giving me the opportunity to talk about pharmacy-led PrEP implementation research, which is my ongoing PhD research. Really excited to be here to share about our work and its preliminary findings. So I think we have heard a lot from Dr. Nita and Dr. Masiza, who had explained very clearly about the HIV landscape in Malaysia. So annually, we have about 3,000 reported new HIV infections. It's mainly in the Klang Valley region, including the state of Selangor and Kuala Lumpur. And the new HIV infections are mainly among MSM. So currently, PrEP is accessible free of charge in the public health clinics since early last year, which is really amazing, and also on an out-of-pocket basis at private clinics and university hospitals. But as of now, this year, there are less than 5,000 people who have accessed PrEP. So perhaps this is where we'll need to look into differentiated service delivery models to achieve a higher uptake of PrEP. So I just want to share that the first thing that got us looking into pharmacy PrEP was because there was a PrEP implementation project in 2018, and they asked the users through a survey suggestions to improve PrEP service, and there are a number of them who say they would like to access PrEP from pharmacies. So community pharmacies are highly trained and accessible, and they are well suited to provide PrEP service through effective task shifting. We have more than 3,000 pharmacies, and they are operating beyond office hours, like up to 9 or 10, including weekends. And adults visit them about 2 to 3 times a month. And they are often the first point of contact for health advice. And also there's an anonymity factor, like people can just walk in the pharmacy and ask anything that they like. And also they get free informal consultation with the pharmacist. So in the era of PrEP choice, it really makes sense to explore pharmacy PrEP as an additional choice of accessing PrEP. So this is an implementation research study. We're looking into measuring the implementation outcomes of pharmacy-led PrEP service implemented at 6 selected community pharmacies in the Klang Valley. So we are looking to understand the acceptability, appropriateness, feasibility, fidelity, adoption or uptake, as well as the sustainability. So these will inform us of the implementation effectiveness and the scalability of this model. So this project has 3 phases. We designed according to the EPIS framework: exploration, preparation, and implementation. So part of the pre-implementation work was we began with the first phase where we conducted qualitative study. We interviewed 18 key population members, 10 PrEP prescribers, and 10 community pharmacists to identify what is the perceived barriers and facilitators. So identified barriers included privacy, confidentiality, affordability, poor awareness about PrEP and pharmacy service, as well as lack of training, staff time, private space, and lab testing service. So we also asked the participants, what do you think would be the facilitators to this service, which include availability of private space, assurance of confidentiality, affordable pricing, adequate training, digitalized assessment, and collaboration with physicians and NGOs. So in the second phase, we started with stakeholder consultation to finalize on the implementation plan. We presented based on the first phase 1 findings, and then followed by training. We trained a total of 18 pharmacists. We start off with online self-paced training. The total duration of video is about 1.5 hours. And the results show that it significantly improved the knowledge scores among pharmacists. And then after that, we conducted an in-person training of a 1-day workshop where we helped pharmacists to familiarize with the workflow. We had case scenario discussion. We also had sensitization training through role-playing sessions. We involved the members from the NGOs. And then before the implementation, we had a dry run. So this is where the pharmacists get to have a practice session at the pharmacy itself with research assistants simulating as study participants. So for the implementation phase, we start off with recruitment over 3 months. We distributed flyers through social media, and we also work with NGOs. We also set up an Instagram account because a lot of Malaysians love to use Instagram. So it's called My PrEP Pharmacy. You can check it out. We had a total of 354 people who expressed interest. 124 did not enroll, mainly because they did not respond or change of mind. And then we successfully enrolled 230 study participants, aged 18 to 49, who are interested to use PrEP. Majority of them are MSM. We send these participants an online link to book an appointment with their pharmacy of their choice. They can choose from 6 study sites. So assessment begins once the person reaches the pharmacy. And this is where we try to simplify things by using a digitalized checklist-based PrEP assessment tool. And then we also use oral fluid HIV self-test kits for the on-site screening, and this is provided for free for research participants. And while waiting for results, HIV test results will take about 20 minutes. The pharmacist will provide counseling, and if the person is eligible and want to use PrEP, the pharmacist will request electronic prescription from physician via telemedicine platform. So this enables same-day PrEP, and also the physician will get to view the assessment information before deciding to prescribe, and this is where we have the remote clinician oversight. And when the pharmacist gets the prescription, and usually it takes about 5 minutes, the participant could get the PrEP at the rebate price, and then after that, the pharmacist will schedule follow-up with the participants 1 month after initiation and every 3 months after. So the pharmacists don't have a lab testing service, so collaboration with physicians is really important here. The pharmacists will advise participants on the recommended lab tests, of which they need to get done at their own expense. So this project is unique in the sense that participants do pay PrEP at the rebate price and also the any lab test. We require a baseline kidney function test to be done within 3 months of initiation. Other tests are strongly encouraged but not compulsory. And so this is where we get real-world information findings, because we really want to find out who are the people who are actually willing to pay to get PrEP via community pharmacies. So let's look at some of the preliminary findings. For the 230 enrolled participants, their mean age is around 28 years old. Majority are MSM. We have only a few trans women and cisgender women participants. About almost half of them are Chinese and the other half are Malay. And so participants are instructed to make their visit at the pharmacy within 1 month of enrollment. But 19 of them did not attend the baseline visit. Some of them withdrew and some defaulted appointment or just did not respond after that. So for the 211 people who attended the baseline visit, 7 did not initiate PrEP.
There's a warning.
Yes.
Does it go?
Oh, sorry. Sorry, I paused my presentation because, okay. Okay, I'm going to continue. One tested reactive and willing to care. And then there's one that reported hepatitis B infection and kidney-related comorbidity. These are criteria that made the person ineligible to start PrEP at the pharmacy, but we do refer to their preferred PrEP providers. And 4 were not willing to start PrEP. So in total, we have 204 people who initiated PrEP at the pharmacy. And looking at the baseline assessment, the most frequently reported HIV risk behaviors among participants is condylar sex, followed by history of STI, and then chemsex. And so for the people who started PrEP at the pharmacy, we do ask them what's their preferred dosing. 65% say they prefer to use on-demand PrEP, and we also ask about the history of PrEP use. So interestingly, we have about half of them who are PrEP naive, and for the PrEP experienced people, about half of them are restarting users who have not used PrEP in the past 6 months. So for the implementation outcome measures, we started sending online survey to participants, and this is ongoing till September. And right now, we have 25 who completed a survey. We do collect information, like additional information on education and employment status, as well as monthly income. So all of these people have obtained tertiary education, had full-time employment, and about half of them reported monthly income of more than 6,000. And we also asked if this is your first time getting tested for HIV, and 60% said yes. So we measure the acceptability, appropriateness, and feasibility using a validated tool. As for fidelity, we measure based on 8 items related to core components of service, and these are adapted from a published study in Kenya. So looking at, on a scale of 1 to 5, the mean score for these implementation outcomes are looking pretty good, relatively high on 4.5 to 5. And then for the adoption uptake, the initiation rate is about 96%, and the retention rate at first follow-up is 85%. As for the second and third follow-up, is still pending. Oops. Sorry. So for sustainability, we asked about the overall satisfaction. On a scale of 1 to 10, they rated 9.3, which is relatively high as well. And all of them will recommend this service to others. We also asked the question, would you like to continue a service, knowing that everything returns to market price, where you have to pay for HIV self-test kits, PrEP medication, and 92% said yes. And there's 8% who prefer not to continue, citing reasons such as I stopped PrEP due to side effects, and also they prefer to get free PrEP from the public health clinic. Okay. Let's look at some of the reasons to continue service. They find it easy, convenient, flexible time, affordable price, safe time, fast and comfortable. Some of them also cited that I like to get my PrEP from a safe and affordable place. Getting from pharmacy gives me exactly that. One cited that is closer compared to the LGBT-friendly clinic, and one mentioned about without having to get a doctor's consultation. And another person said about personalized care, and pharmacy is really friendly and easy to deal with. So for the second outcomes, you look at attrition, mainly due to loss to follow-up. And then average visit time is about 30 minutes. We have linked to 3 persons to care, and this includes 1 seroconversion. The person reported no symptoms, reported good adherence to on-demand PrEP, however, inconsistent condom use with single partner unknown status, and we have linked this person to care. So lessons learned so far, we have low reach among other key populations, so we would need targeted recruitment strategies for these populations. And we also need to ensure there's availability of physicians for clinical advice during pharmacy operating hours. There's high turnover of pharmacists. We need to make sure that we need to train a new pharmacist. And we also need to ensure broader training beyond PrEP. And also for the lab tests, we need to provide lab test options and packages attractive to them and ensure close follow-up to ensure that they get their lab tests done. So for the next steps, we're looking into continuation of service. We'll send out a survey to participants' pharmacists. We're also looking into continued partnership between pharmacy and telemedicine providers and ensuring that HIV self-test and PrEP will be more affordable and also incorporate online consultation, making a hybrid approach. We also plan to present our study findings to MOH, hopefully to be considered as one of the DSD models in the National PrEP Guidelines, and also the potential of scaling up to other states. So I would like to acknowledge the support and contribution of our funders, my supervisor, research assistants, and collaborators. And that's the end of my presentation. Thank you.
Thank you, Yanni, for that really whiz through of pharmacy-led PrEP, that work and implementation that you've been doing extremely well. We look forward to a couple of questions after this. So next up, we have Nick Kamaruddin, who is currently the Chief Brand Strategy Officer at Sunway Group, overseeing the group brand marketing and communications, including sustainability, brand communications, corporate responsibility, and the Jeffrey Chia Foundation. Tasha is going to be telling us how the corporate sector can be involved in the HIV response. And the title of her talk today is Corporate Engagement, Tripartite Strategy, a Catalyst for Achieving Ending AIDS by 2030. Thank you.
Thank you, Iskandar. Last presentation of the last evening of the session, so I'll try to keep it interesting and brief. Okay, I think for those of you who are not familiar with Sunway, we are 50 years old this year. We started in Malaysia. We're still very active in Malaysia, and it started off with the theme of sustainability by converting a once tin mining area to where we are now, which is Sunway City, Kuala Lumpur. We are 13 business divisions wide across construction, healthcare, retail, hospitality. If you do ever come to Malaysia, which I hope you would not miss the name Sunway here, there, and everywhere. Our founder, we're very fortunate to have our founder and chairman still with us, Sir Dr. Jeffrey Chia. He unfortunately can't be with us for this session, but it is through his interests how to eradicate and eliminate HIV in Malaysia that started this wonderful journey with the Malaysia AIDS Foundation and the Malaysia AIDS Council. We see this journey with our partners all here is through as part of our Sustainable Development Solutions Network and SDG goals that we started in 2015. It's very important for us to hit each and every one of the 17 SDG goals. And of course, this partnership looks at various parts of the SDG plans that we have. A little bit on Malaysia. As you know, famously, we are in between Bali, Bangkok, and Philippines, for those of you who don't know where we are. We are into east and west, and where Sunway is mostly in the west part of Malaysia. In terms of the Peninsula Malaysia, it's our hometown. You can see the KLCC towers there. It is a thriving city within Asia. In terms of the presence of Malaysia, we have thousands of expatriate workers and people who live and migrate there on a yearly basis. And in terms of the economic hub, of course, our major focus before this was manufacturing, but we are growing into looking at data centers, and we are looking at multinational corporations being HQ in Malaysia. In terms of the geographical aspects of health financing, West Malaysia is seen as, well, is predominantly a lot of the economic activities are based in West Malaysia, and the beautiful parts, the beautiful islands are in the east part of Malaysia, which is Borneo, Sabah and Sarawak. This is where it gets a little tricky because it's bigger in terms of, compared to West Malaysia, and in terms of accessibility of health and funding to get to there is a bit more difficult. If you look at the total fund of Malaysia's HIV funding source, it's broken down into domestic public, domestic private, international, and it totals up to around 90 million a year in 2022. In terms of the National Strategic Plan of ending AIDS, 75% from the total funding goes to the NSPEA Strategy 1, which is the treatment and care, as all the panelists here has explained earlier. And this would include the first-line ARV counseling services, group support, and so on and so forth. Where do Sunway comes in? Well, I think we've heard since the beginning of this whole AIDS 2024 is that private partnership is becoming more important because, unfortunately, since the pandemic, there's a lot of division in terms of where the money should go globally. And where we see we play a role is to look at the areas where it needs most help. We started our journey with the Sunway Hope Borneo program, and this is in the east part of Malaysia. And how it works is we look at the cash incentives of low-income patients and HIV and either chronic disease to cover high costs of travel and logistics for hospital appointments in town. These towns, in the next slide, you can see is far in between, and most of the people living in West Malaysia are under the poverty line. So we address issues such as poverty and challenging infrastructure. So one of the things that, with the funds that Sunway gave, was to look at the transportation, which is providing vans. And if you look at the number of patients that we have, it's looking at 230 of chronic diseases, and we have committed to over 5 million ringgit, which is equivalent to around 1 million USD throughout the 5 years to make this happen. Sunway's corporate responsibility, of course, goes beyond this program. And what we do, one of the things that we've been doing for years is, of course, the Sunway Food Bank. And through Hope as well, not just to provide the services for HIV, we also provide food for the underprivileged. One of the things that we are very proud of in terms of the partnership is the Tratak Kasih Tok Nan, Home Away from Home, where the patients can come and stay comfortably with their family and children to receive treatment. I've had the pleasure of seeing this. It's just wonderful to see that it's very comfortable. The children there are safe and welcome while all the patients receive their treatments. This is just a little showcase of the launch that we did. Prof. Adiba was there and Dr. Anita was there as well for what we did last year. We have over 40 support groups conducting help those in need in this area, and this is very important as I think all the other presenters mentioned, mental health is something that we have to take seriously when we do help. What we hope to do is creating a long-lasting positive impact across in East Malaysia. And I will end on this it's a full slide. So basically, we need continuous partnership within private sector, NGOs, and of course government. We can't achieve this alone. CS corporate responsibility, where it's known in Malaysia, still holds to empower the beneficiaries and hope to motivate the treatments and to improve the quality of the lives that we touch. I think what I heard Helen Clark spoke yesterday morning and how it will be more and more difficult in order for private partners to choose which path to help because the funding is getting smaller and smaller as there's so much issues in the world that we have to address. But I think for a company like Sunway, we are here to stay and we're here to help. And if this is one of the channels that will improve the lives and community of Malaysians, we will definitely do so. Before I end this presentation, I would just like to say thank you to a colleague of mine, Bernard Paul, who's here. He is the one who actually did most of the work to spearhead this project within Sunway, and without his help and the team from Malaysia AIDS Foundation, Malaysia AIDS Council, and the Ministry of Health, this partnership would not have worked. So thank you, everyone. And I'm 7 minutes ahead of time, Dr. Iskandar.
Absolutely, Tasha. Thank you so much for keeping to time. You certainly made it up for all the other presenters, including myself, who overspoke. I'm going to use my prerogative also as chair, maybe to ask you to stay on for an extra 5 minutes of your time and maybe just give an opportunity to ask questions. So I'd like to open up to questions if you may have. I have several questions, but I'd like to give it to the floor, the opportunity. And I see Heather coming up.
Heather Marie Schmidt from WHO and UNAIDS, and I wanted to say a big congratulations to Dr. Anita particularly for her leadership and for being a PrEP champion. It's amazing to see the progress in Malaysia over the last couple of years. So with the clear data, and thank you for the data that you presented, Dr. Mazlisa, that was really great to see. So really showing the benefits of PrEP in Malaysia, attracting individuals to services for HIV testing and prevention, likely contributing to earlier diagnoses among people. What is needed, or what is the roadmap to embed pharmacy PrEP? As we've seen, it looks quite successful from what we've seen so far from Yan Need's presentation. Assuming that it stays that way for the next 3 months, what is the roadmap? What is needed to embed pharmacy PrEP as part of Malaysia's mix of prevention options and ensure sustainability going forward?
Okay, thank you for the question. Actually, we already been discussing with Yani when we try to develop our own national guideline for PrEP. And one of it is, of course, the government-led PrEP, pharmacy-led PrEP, and also to incorporate the GP-led PrEP into our guidelines. Because, of course, we need to give our clients, our communities choices where they can get PrEP. So that is already in line, but of course we need to get more information from the study itself before we can actually put it inside our national guideline. But of course there's a lot of things that need to be done to be discussed with the pharmacies in terms of the government, I mean the law behind it, because so far we don't have that kind of things that where we can incorporate the testing, I mean the PrEP, the pharmacy-led in terms of I mean a lot of things have to be discussed before we can put it inside our guidelines. I think it's already in the pipeline, yeah.
So that's good. At least the initial discussions have been happening. The possibility maybe of a public-private partnership also, similar to what happened in COVID, but of course questions around the legal framework as Yanni has also put in her conclusions. But the important thing is that the discussion also has started. So thank you very much, Heather, for that question. And let's keep the discussions around that going.
All right.
Our next question, Faiz, right. Thanks.
Thank you all the panelists for the great session. All right, I'm Faiz Jamaluddin from Malaysia. I have 2 questions here. First question for Sunway representative, what is the good practice that Sunway Group have in terms of workplace policy and how you plan to manage in workplace? My second question goes to Dr. Anita. Statistics shows that increasing numbers of people infected with the HIV, especially young age 18 to 25 years old. So recently, people pushing up their Ministry of Higher Education to mandatory to undergo HIV testing for the new intake. So based on the WHO guideline, it must be voluntary to get tested. So any initial planning from the Ministry of Health about this matter? Thank you.
So
Dr. Anita's question is longer, so maybe she'll start
so,
first.
Okay, Dr. Anita can take that question first.
Thank you, Faiz, for the question, but I think I am not in the position to respond on behalf of Ministry of Health because I am no longer with Ministry of Health. all right? So what I can tell you about recent, I know you are referring to the recent issues that was brought up in the parliament about highlighting the increasing number of HIV among tertiary students, right? Tertiary level students. So you know, there are still debatable issues about making HIV test mandatory for enrollment. Even, you know, that is something that is no, how shall I say, not a confirmed or direction yet, because there are a lot of issues around that particularly screening, mandatory screening or compulsory screening for higher or tertiary students. So I do not want to comment because it will be a negative implication later on with the government, specifically Ministry of Health, because I am not in the position to say anything about that. Thank you.
Thank you, Faiz, for the question. I always start the answer by saying we can always do more. But what we are doing in Sunway is advocating awareness on how to include HIV issues into conversations. I think last year itself, we invited the Malaysia AIDS Foundation to speak to our staff, and it is part of our policy to be inclusive because we have to as part of the SDG goals. However, we are being a Malaysian company, although it is a public listed company in Malaysia, we are also not, we have to be aware of the sensitivities of what the country, the majority of the population of the country sometimes rightly or wrongly feels. That does not discourage us to do it, but we just want to make sure that it happens along the lines of we are promoting it and encouraging it positively rather than us being an outlier. I think one of the reasons Sunway took up this partnership is because we just wanted to show to the Malaysian, especially with the businesses around Malaysia, if Sunway can take a topic like this and champion it, there is no issue for the rest to follow through. And we hope, at least after the 5 years of partnership, it will open a lot of more doors to MAF and MEC to talk to businesses like us. But we can always do more, and doing more is what Bernard and I think about every day, and hopefully this is just a work in progress.
Thank you. And I can also make the testament that, I mean, I think what you've been doing, other sectors of the corporate sector have also followed through. So I think thank you for doing what you're doing, as well, Bernard, of course, because you've also been very much involved. With respect to just the issue around HIV testing in universities, Malaysian AIDS Council also has been engaging in those discussions. We wear sort of a neutral cap, and some of those discussions have been happening. The extent of which, the specificities of that, I cannot specify at the moment, but we're also assisting with those discussions, Faiz. Thank you very much. Could we have your question? Just introduce yourself, please, and tell us where you're from.
Yes, I'm Nitha Theosabjur, and I'm a PhD student from Monash University, Australia. I have two questions. One question about PrEP growth, and the other question about the pharmacy PrEP. So the question about PrEP growth, so I wonder if you know how many clients who didn't come to the follow-up visit for maybe a few visits and then come back later. Like, do you consider that as a loss of follow-up, or like, and yes. And the second question about the pharmacy PrEP. So I wonder, is there any privacy issue doing the HIV screening and counseling in pharmacy? And like, is there any private room? Like, how do you do it? Thank you.
So Dr. Masliza, first,
Yes.
please.
Okay, thank you. Regarding the data, I think I don't have the specific number, but we do follow up these kind of patients, our clients, because for your information, our data is online, is website, so everybody will predict all the data inside, and we have our PrEP navigator, as I said, the community healthcare worker who help us with the those who are not coming, lost to follow up and everything. What we can do is that we make sure that our PrEP navigators keep following up for them and asking them what is their problem, is it because of logistic issues and everything, whether we can reschedule their dates or follow-ups and everything. And then if they come, we do have the numbers, but as I said, I forgot the numbers, but we do follow up everybody, and the number that I show you, the loss of follow-up, is the one who are really lost to follow-up. But the rest of them, of course, in between, we do have, sometimes they lost to follow-up about 1 month, and after that they come back. As long as they come back and restart the medication, we allow that for that kind of situation. So the follow-up for our client is, with the help of our PrEP navigator, is something crucial and very important for us. Thank you.
Hi, thank you for the question. So, like I mentioned, that during the formative research, we learned that one of the identified barriers is privacy, and the facilitators would be the ability of private room. So, for the 6 study sites that we included, all of them have a private room for the testing, the assessment, consultation. So what happens is when the participants come to pharmacy, they will tell maybe the front staff, like, I'm here for PrEP, I made an appointment with a pharmacist. So directly they are directed to the private room with the pharmacist. So as we do encourage everyone to make appointment first, so that the pharmacist will have ample time for the PrEP service. Yeah, thank you.
Thank you. We have a question at the back. Sorry to have kept you waiting for so long.
Thank you. My name is Dr. Manoj Kuri, and I'm the director of the Churches Commission on Health and Healing of the World Council of Churches. First of all, I would like to congratulate you on this brilliant presentation, and all of you. It's a great, as an Asian, I'm really proud to see this, especially with such low PrEP uptake all over the world. So Malaysia, it's a great example. And also the collaboration between the Malaysian AIDS Foundation and Sunway and also the government. My question is that this is about the ethical justification and guidelines from the faith perspective. Would it be possible for you to write something up? Because this is very, very important for us in various faith contexts. And it can be a great guide for many Islamic countries, not only Islamic countries, other faith communities. So it's just a request, if you can write some guidelines and make it available, it will be very helpful.
Okay, thank you actually for your information. Minister of Health has already come up with guideline, all right? But and the guideline more technical rather than for general population or targeting the religious group. But what we plan to do is that we do not want to go too obvious, to general population, because as you know, some religious scholars are in favor or they accept it, in line with medical or with Islamic ethics. But still, we still have another quarters who are against it. So we do not want to stir too much. So we rather do it quietly, and then what is important is to have a policy that PrEP must be given, provided by the government. That is the ultimate goal. PrEP is one of the preventive package. It must be given by the government, and the private sectors are already providing it. Those who have the money, they can go to the private sectors or the pharmacy, they can pay. But majority at large, those key population, especially the young one, they can't afford. So they will come to the government. The government must provide, and that is the message. Okay.
I'm afraid you just popped up. Do you mind just keeping your questions short? And then, if that's okay, I apologize about that.
No, sure. I will be brief. I think it depends on the response, how long it will take. My name is Rafa Hamers. I work for Oxford University. I'm based in Jakarta, so I work in Indonesia. So I came to the session to hear the experience from Malaysia because Indonesia is following later and is exactly at the point, I think, where you started. Now we're out at a large-scale oral PrEP with very similar issues related to religion and sensitivities. So I think I just want to follow up on the last point, because I think that's why I was so late to get up. I think the precise issue is that the government is providing in Indonesia, like you are, for free, but key populations do not often feel comfortable to going to these exact general health clinics. So they go to NGO and private clinics. They prefer to go there. In Indonesia now, finally, there is an understanding that the PrEP will also have to become available through that mechanism. So how do you look at that? Because I think to really make a jump and have an impact on the epidemic, and I think it was shown in the first slide, you have to go really big, right? You have to reach out beyond the current numbers. So to me, it sounds that that jump to include the private sector has to be made. But if there is no change in how the funding works and how people have to contribute to it, how do you see that challenge, and how do you see that can be addressed or solved as a hurdle? Thank you.
Yeah, I agree with you. You know, to have an impact, the coverage of PrEP has to be large scale. So at the moment, I think because it is still pilot intervention, so what we are already in the pipeline is getting approval or the policy approval by the government of Malaysia, specifically Ministry of Health, that to agree that PrEP must be provided by the government, all government clinics. So once it is available, made available in all government health clinics, anybody can come and get for free. All right, they pay one ringgit Malaysia just for registration, and they get everything, including testing, lab tests, and everything. Now the issue is how do we scale up? Right, this is about the government. We cannot assure how much we are getting. Number one, we must get the policy ready. Once the policy approved, then next come in with the funding. Now I know that we need large funding to scale up. This is where the role of CSR, international partner, comes in to help the government or to help the country to scale up, you know, in a larger scale, impactful enough to bring down HIV. Right? It is challenging, yes, but I'm quite positive that the policy, but the government now is looking at the second option, which is co-funding. If you look at the estimate that I showed, you know, both co-funding or full funded by government shows same decline, almost same decline. So there is two options. To get a buy-in from the government, okay, we have to come up with co-funding, but with the rate of PrEP very minimal, which affordable by most people, right? So that is one way that we are looking at how we could scale up this. But of course, we do not want to limit CSR only with Sunway. We are also hoping that Malaysian Foundation, Malaysian Council will look you know, to other funders to help the government working together to scale up PrEP with private sector as well as community pharmacy-led, all right? Because those who have money, it is still costly if they go to private sector. Still same thing with pharmacy. It is still costly. Only those who have the money. But if the government there is some form of private-public partnership, the medication funded by the government and the rest of the service given by private, then we can bring down the price. Then probably we can also scale up faster, all right?
Thanks very much, Dr. Anita. I just want to ask one last question, and that to Tasha, really, because you have been an essential partner, so the Sunway Group has been an essential partner in this response. For those of the delegates here who are not from this country, and I think some of those answers may have been addressed, how can they replicate a similar corporate sector engagement to the same extent that we have been fairly successful here in other countries?
I think the simple answer to that direction needs to come from the top. So for us, it was very easy because our founder and chairman, Tan Sri Sir Jeffrey Chia, when Prof. Adiba came to see him a few years ago, the minute she finished the presentation, he said to her, we need to bring dignity back to all the communities, and this includes, you know, people who are infected by HIV. When he said that, it mobilized the rest of us to get involved and focus on the situation and how to help. I think if more private sectors come together, they should, and say this is not about what we can do for corporate responsibility, but as part of their nation building to build, you know, for Malaysia, for Malaysians. I think that's a good start to encourage. But I always say, the encouragement and direction needs to come from the top. If not, it will never work.
Thanks very much. So in closing, I apologize once again for keeping you here longer than you've had to. Thank you very much for staying right till the end, and I hope you've had some insights into some of the challenges and opportunities of PrEP implementation in Malaysia. I just want to say once again a big thank you to the Sunway Group, both Tasha, Bernard, and your team for assisting, as well as the Malaysian AIDS Foundation in making this symposium happen. So with that, I close and thank you once again.